So, hi, good evening, everybody. This is Dr. Apoorv Mehra, and today we are going to discuss about the first Prof mini test that you have given on MedMiracle app. We have Dr. Kavan, who's going to discuss how to approach the questions. It is important to study. It is very important to revise. But the most important thing comes when you are on the pitch and you have to play. You can do rehearsals, you can see the lights, but till the time you don't know how to give the paper, how to attempt the question, how to see the hidden, you can never get the right answer. That reminds me of famous Michael Jackson. Michael Jackson, throughout his life, has never ever performed in a live session without doing a rehearsal in the same auditorium, on the with the same audio, with the same lights. He will never take the risk. He said, I have to rehearse and practice. And then he said, finally, when you go there, the nerves get on you. So today you have a man who performed on the highest stages for last 2 years and performed beautifully. He was doing fantastic in the grand test. To top it up, he finished with topper of all India twice, not once, twice, with a 2-digit rank in less than 25, both the times, 18 and 21. Who can be better to tell you how to approach the questions, how to see that hidden line? I will not be wasting more time. I will hand over to Dr. Kavan Parikh. Just like the last time, I wish a great session. All the best, Kavan. Thank you very much.
Thank you, sir, for such a generous introduction. And good evening to all of you. I hope I'm audible and I hope you can see the screen which I've shared, the presentation, right? I hope that all those who have joined us in this session have given the test today, which we had uploaded, the 25 questions of first Prof subjects, right? So I want to know from you, how was your experience the test? How did you find the questions? Did you find them easy? Did you find them difficult? So I'm getting the response that the screen is not visible. Someone else, if possible, they can please give their inputs whether the screen is visible or not, so that I can intervene.
Kavan, the screen is visible.
Okay, thank you, sir. Thank you. So yes, that is the first slide. MedMiracle next. So how was your experience of the first test? I hope you like the questions, and I hope you could understand what we are targeting and what the future exams are going to target, right? So basically, it is the next level of preparation, and in next, the one thing which is being always talked about is regarding the integration of subjects, right? And in the first Prof, the pre and paraclinical subjects especially, they are the ones where we have not yet evidenced what exactly the clinical integration could be. So we have tried to integrate and make questions of a similar pattern. So let us start. So this was the first question. I hope you can see this question, and what actually this question was aiming at. So you might think in the first go, if this question comes in the exam, right, you might think that this is a question of maybe orthopedics, this is a question of maybe radiology, because an x-ray is being shown, right? And then also think remotely that this might be a clinical integrated question of anatomy, right? So basically we had a trauma case in which a patient had a fall on the shoulder, right, from a running motorcycle, and then the position, the clinical position is shown in this image, right? And the x-ray of that same patient is shown, And then you are asked that which is the likely nerve which can get injured in this case. So basically, here, if we consider this question from anatomy point of view, then we should know that what are the important nerves which are in relation to the bone which is shown in the given X-ray. So first you have to make a clinical diagnosis that what this condition may be. So you can see here the patient is, hello. Okay. So you can see that this is the typical position in which the patient's arm is there, right? It is resting, the hand is resting above the head. And if you see the X-ray, you can see that there is tilting, there is upward tilting, and the head of the humerus is facing downwards. So basically, what would have happened? The patient would have fallen from a motorcycle, and there would be impact on the shoulder joint from the superior aspect. And because of the impact on the shoulder joint from the superior aspect while falling, the head of the humerus has drifted downwards. So there has been a dislocation of humerus from the glenoid cavity. So basically, this was a case of the inferior dislocation of shoulder. It was a case of inferior dislocation of shoulder, which is also known as the luxatio erecta, right? And now, when the shoulder joint gets dislocated in this manner, now you have to think that which nerve would be probably damaged in this case. So if you recollect your anatomy, then we have studied that the axillary nerve is in relation to the neck, the surgical neck of humerus, right? So when there is damage to the humerus, or when there is dislocation to the humerus, or a fracture of the neck of humerus, then axillary nerve is the most common one which is likely to get injured. So here also, because of this dislocation, inferior displacement of the head of the humerus, there will be damage to the axillary nerve. So the axillary nerve is the answer to this question, which is most likely to get damaged in this case. So this same question can come in the form of a manifestation of axillary nerve injury as well, right? They can tell you that there is difficulty in abduction of the shoulder joint, or there is difficulty, or there is a sensory loss in the regimental badge area on the lateral aspect of the hand, right, on the upper arm, right? So in that way also they can give you a hint about axillary nerve. But because I wanted to integrate this question, I used a clinical image which is usually seen in an orthopedics emergency, and the X-ray, which is the first radiological investigation which is done in any case of trauma, especially for orthopedic conditions, right? So this is an example of how the integration of the basic sciences is done with the clinical aspects. So I hope you could understand this concept, and I hope you could think about this question in this manner and solve in your exam which you gave, right? So this is about the first question. Since this is an orthopedics related question, so basically this was the explanation which you would have got, right? So the given scenario, the given clinical position, and the X-ray were suggestive of luxatio erecta, right, which is also known as the inferior shoulder dislocation. And the most common nerve to get injured in this condition is axillary nerve, because it is located around the surgical neck of humerus. And shoulder joint itself is the most common joint to undergo dislocation because of the great range of mobility, right? The dislocation of shoulder joint in itself is a very, very important topic from orthopedics point of view. Anterior, posterior, inferior, all different types of dislocation. That the most common complication of the shoulder dislocation is recurrent shoulder dislocation, right? And that is very commonly seen in clinical practice. Whenever there is axillary nerve damage, there will be weakness of shoulder abduction, lateral rotation, based on the muscles which are being supplied by axillary nerve, mainly the deltoid muscles, right? And there will also be the sensory loss over the regimental badge area, right? So this is basically regarding inferior shoulder dislocation in a clinical point of view. In a clinical point of view, we have discussed the inferior shoulder dislocation. So now coming to the next question. Coming to the next question. Okay, so coming to the next question. So now in this case, you are shown an image and you are given a clinical presentation, right? So we have a child who has presented to the ophthalmological OPD with leukocoria, right? So there is a leukocoria in this child with a difficulty in upward gaze and convergence retraction nystagmus. Imaging studies revealed the diagnosis of trilateral retinoblastoma. Which area of the cross section would be involved in this case? So basically, we have tried to integrate ophthalmology with neuroanatomy with neuromedicine, right? So we have tried to integrate all the three aspects. So basically, whenever we talk of leukocoria in a child, the first thing that comes to our mind, that should come to our mind, is retinoblastoma, right? So retinoblastoma is the most common cause of cat's eye reflex or leukocoria in a child. Now, along with leukocoria, this child is also having problem in upgazing, right? In upward movement of eyeball, retraction nystagmus also. Now, you don't need to think about the diagnosis because they have already given the diagnosis of trilateral retinoblastoma. Now, here, the only one thing which you should know is what is trilateral retinoblastoma. So basically, it is bilateral retinoblastoma. It is bilateral retinoblastoma plus pinealoblastoma. It is bilateral retinoblastoma plus pinealoblastoma, that is the tumor of the pineal gland. Now, if you recollect the anatomy of the pineal gland, the located superior to the superior colliculus, right? It is just located on the upper aspect, on the cranial aspect of the superior colliculus. So if there is any enlargement or there is any tumor of the pineal gland, then it is going to cause compression syndrome, compression symptoms on the superior colliculus, right? So if you see, this is the section of the midbrain at the level of the superior colliculus, right? And these are the three areas which are marked, which are involved in three different very important brainstem syndromes, right? In the cross-sectional anatomy, in the neuromedicine, we discuss these syndromes very often, and these are the three areas. So now it is very logical that if the pineal gland is situated above this area, then it is going to cause compression symptoms on the superior colliculus. So the area involved will be area A, right? So the area involved will be area A. So our answer will be option A, area A. And this syndrome is known as Perinod syndrome. And this Perinod syndrome, very important cause is pineal gland tumors, right? One of the most frequent cause of Perinod syndrome in a child is a pineal gland tumor. And here we have tried to integrate the pineal gland tumor with retinoblastoma in a condition known as trilateral retinoblastoma. So we have tried to integrate ophthalmology with neuromedicine and neuroanatomy. So basically, this is to revise the anatomy of the pineal gland. You can see the pineal gland is located just above the superior colliculus. It is located in this region. And this is the MRI of a child which is showing the pineal gland tumor, right? It is an image of pinealoblastoma. So you can get an image-based question integrated, radiological image integrated with a similar scenario, right? So this was Perinod syndrome. The symptoms which were shown, upgaze palsy, convergence retraction nystagmus, these are all the symptoms of Perinod syndrome because of involvement of superior colliculus, right? Because it is the center of relay of the pathway of vision. This is trilateral retinoblastoma, bilateral retinoblastoma plus pinealoma, right? It is a common cause of dorsal midbrain syndrome. What were the area B and C? The area B is involved in Benedict syndrome. Area C is involved in Weber syndrome, right? So these are cross hemiplegia syndromes of the midbrain, Benedict and Weber, right? So these were the different areas which were shown in the image in the question. I hope you could figure out this entire combination of topics which we have created. This is the third question from physiology, asking regarding the pacemaker potential in the SA node, right? So in the SA node, what are the changes, what are the ionic changes which will generate the pacemaker potential? Now here I want to discuss a very common bias which gets created in our mind when we see this option, all of the above. So whenever you see this option, you always get tempted that yes, this might be the answer, right? So whenever you get this option, please make sure that you read the other three options very carefully. Now, if you remember the pacemaker potential, then yes, it has the role of sodium channels. It has the role of calcium, potassium current as well. But still, the answer is not all of the above. It is not all of the above because you should remember that the sodium channels which are being involved are not of the fast type. They are the slow type channels which generate the funny current, IF current, funny sodium current. Then you should also remember that the calcium channel are not L type. They are the T type of calcium channels which are being involved, the transient type. And this is the correct one, decreased outward potassium current. So your answer becomes option C, right? Now these are the minor changes which are being done by the examiners in the questions, right? They will slightly change the option and they will try to see whether you have read it in entirety or not. So these are the contributors to the pacemaker potential. We have the slow type of sodium channel, the T type of calcium channel. Now this is the difference between an ordinary student and the one who gets the rank. This is known as the entirety of knowledge. You should have the complete knowledge of something that you are studying as far as possible. So this is the diagram of the pacemaker potential and followed by the action potential in the heart, right? So here also you can see the description. We have the funny type of sodium channel, transient T type of calcium channels. Then L type of calcium channels result in the action potential. They does not result in the pacemaker potential. They are a contributor to the action potential. And then you have the outward current because of potassium channel opening. So I hope you could get this concept, that don't get misguided by all of the above option and read each and every option completely. Read each and every option completely. Don't miss out on the subtle changes which are being made. Coming to the next question. So this is an integrated question of physiology with an image. So here a young boy had a leg sprain while running and the mother immediately applied pressure which provided relief, right? Now the mechanism of pain relief which is being done here, it involves which part of the spinal cord? So here you can see A, B, C, D. There were 4 labels, right, in the image, and label A. Label A is the answer, right? The dorsal horn contains substantia gelatinosa of Rolando. It contains the substantia gelatinosa of Rolando, which is the main center, which is the main relay center for the gait control theory. So basically, this was a clinical question related to the gait control theory, right, of pain relief. And the center is substantia gelatinosa of Rolando, which is located in the dorsal area, which is located in the dorsal gray matter area, right? And here it is known as area 4. Area 4 is known as the substantia gelatinosa of Rolando, which is the main center for the pain relief in gait control. So here you can see basically how this mechanism works. So there is an inhibitory interneuron. There is an inhibitory interneuron which is keeping, in the normal state, it is keeping the pain transmission off, right? It is reduced. Now what happens when there is a painful stimuli? The type C fibers, they will inhibit this inhibitory interneuron in substantia gelatinosa of Rolando, and as a result there will be increased transmission of pain signals. Now when you provide massage or a pressure to the same area, the A beta fibers will again go and stimulate this interneuron, right? This inhibitory interneuron is being stimulated by the A beta fibers, and that again will cause the normal state, right? And it will result in pain relief. So basically this is the gait control mechanism in short, where there is an inhibitory interneuron which is inhibited by type C fibers causing pain sensation, and then when you provide massage, the A beta fibers will stimulate the interneuron and it will result in the reduction in pain sensation, right? So this is the basic concept of the gait control theory. and you were just asked what was the center in the spinal cord where the gate control mechanism works, right? So I hope this question was doable. It was just a basic concept but modified into a case based manner. Also remember, this is a very common way in which the options are being framed, A, B, C, D, and then here it is random. So don't mark option A in the haste, right? You should see that the label A is given in option C. So you have to mark option C and not option A. This is also a mistake which happens when we are in a hurry in exam. Coming to the next question.